Um, there we go. All righty, everybody can see?
Yes.
Yes.
All righty, so as I already said, I probably went overboard on number of slides, and even as fast as I talk, I'm probably not going to get through them all. If everybody's interested, we can certainly set up another time or reschedule for September or whatever. I'm also supposed to be going to the fellowship council, although I think I should be able to do it. It looks like I can do it by Zoom. So, and I asked to have the room until 6:30, anticipating that I was going to run late and or be answering questions. So I put my standard, why are you not going? Come on, switch to slide. Oh, I got cocky. Come on. There we go. So here's my standard disclaimer that I am not giving you medical advice, that this does not replace talking to your primary care provider, purely educational and helping you to be able to understand more and ask better questions. So fairly quickly, just wanted to go over blood pressure. There's a couple of key things here. Blood pressure is, obviously, there's two numbers. There's the top number and the low number. The top number represents the highest amount of pressure that is in your blood vessels, and the low number, the lowest number. So why is there pressure in your vessels? Well, your body is a self-contained system from the standpoint of your blood. So there's always a certain amount of pressure in there because, unless there's a real problem, it's all contained in the blood vessels. So that means that you have blood vessels that are full of blood. So there's always going to be a certain amount of pressure in there. The high and the low number is tied into what your heart is doing. So when your heart squeezes, which is what we call systole, that's when the number is the highest, because the heart is squeezing, that's pushing the blood out into the blood vessels and getting it circulated. That's the peak amount of pressure that's in your blood vessels at that point. And then the heart rests, also known as diastole, and that's when everything relaxes. But it never goes to zero, because you always have a certain amount of pressure in there, because the tubes, which in essence are what blood vessels are, picture it as a hose. So my analogy is usually, if you hook up a hose to water and you turn on the water, but you have the spray end closed, and you look at it and you see that the hose is full of water, but it's not going anywhere. Picture that in a whole bunch of loops going throughout the body. So that's my best visual from the standpoint of there's always pressure in there. And then squeezing, pressure goes up, relaxing, pressure goes down. So both numbers are important. People think it's only the high number, but both numbers are important. We like to keep the numbers around 120/80 is the optimal, which, if you're figuring that out, means there's only a difference of about 40 millimeters of mercury in between the top number and the lower number. If the numbers are going too high, there's a number of things that happen. It puts a strain on the blood vessels because the pressure is going high and high. So using that hose analogy, imagine if you never turned on the spray, but you hooked the one end of the hose to a 4-inch water outlet, and how much more water would be coming into it. It would put a strain on the sides of the hose. So if the pressure is too high, it's putting a strain on the blood vessels. And there's a number of things that make that happen. You actually have a thin layer of muscle within your blood vessels, and that can get stretched out just simply because of aging. The blood vessels get stiffer, and that means they don't contract as much as they did when you're younger, and they can just kind of stay a little bit more open, and that can cause the pressure to rise. If the pressure in your blood vessels is too high, that means your heart has to work harder in order to circulate against that pressure. And like any other muscle, If the heart is working against resistance, it's going to enlarge. And then you end up with heart enlargement, which is bad on a whole lot of other cases. So that's why it's so important to keep the blood pressure regulated, keep it in a good range, because if it's too high, it puts pressure on every vessel in your body, and that includes ones that you don't think about, including the vessels that are going to your kidneys, are going to your eyes, and are going to your brain. So all of those are affected if your blood pressure is too high. And it's mostly asymptomatic, so that's why it's referred to as the silent killer, that a lot of people are walking around with their blood pressures elevated, and they're getting what we call end organ damage, which is damage to pretty much everything, but especially those three areas, the brain, the eyes, and the kidneys, and creating damage in there. Believe it or not, this is one of the times when race really does matter. Caucasians typically get more damage to their eyes from high blood pressure. African Americans typically get more damage to their kidneys. If you walk into any dialysis center at any time, I would pretty much bet you that there will be a higher number of African Americans on dialysis than there will be Caucasians. So there are factors in there that make a difference, but you don't want to have the pressure anywhere too high, and that's why it's so important. A lot of people, you might have heard about white coat hypertension, that, oh, my blood pressure is just up when I go to the doctor's office, it's fine every other time. My way of dealing with that is to say to people, if your reaction to stress is your blood pressure going up, then it's more than just when you're in the doctor's office. It's when you're stuck in traffic. It's when you're having an argument with your spouse. It's when you are fighting with the IRS. If your response to stress is your blood pressure going up, it's going up more than just when you're walking into the office. Now, what's made things a lot easier over the years is now, of course, it's very inexpensive to get your own blood pressure monitor. And I suggest that every household have one of those. You can get them on Amazon. You can get them in virtually every pharmacy. All you have to do is wrap it around your arm and push a button, and it takes your blood pressure. What you should not do is take it multiple times a day and get anxious every time you see a slightly high number, because that's only going to make you go up. The important thing is, what is it? It will vary throughout the day. It's generally lower in the morning when you've been sleeping, and it's generally higher at night when you've been dealing with the stresses of the day. It's good to know what it is at different points, but you don't have to get obsessive about it. Keeping it around, checking it a couple times a week at different points in the day is a good thing to do, and especially if you're being treated for high blood pressure, that really gives your primary care provider, your PCP, a lot of good information as far as how your blood pressure is varying throughout the day. And the last thing that I wanted to say about blood pressure is, a lot of times people only want to take one medicine. Just give me one pill. I want to take one pill in the morning and I don't want to have to worry about it. And there are now a lot of drugs that have combination. There are four main categories. There are more than that, but four main categories of blood pressure medicine that we use. There's ones that are called ACE inhibitors or ARBs, that affect the chemicals being released from your lungs into your blood vessels to make them squeeze. There are ones called beta blockers, which is pretty much the oldest category, that affects receptors in the blood vessels themselves and your heart rate, and decreases your heart rate. There's calcium channel blockers, which affect the regulation of sodium and potassium that is going on in each of your heart muscle cells all the time. And then there's diuretics, which act at the kidneys and affect how much urine you're going to produce. People don't like to be on diuretics because it makes them pee more, but if you think back again to the hose analogy, if you have a lower volume in the hose, that means the blood pressure is going to go down. So that's a reason for the diuretics. A lot of times people will only want to take the one medicine. Well, I've been taking this for years. I know I do well on it. I just want to keep taking that. Just give me a higher dose. And so the dose keeps going up and up. The problem with that is twofold. A, it means that you've got a higher chance of the side effects related with that particular drug because you're going on higher doses. And B, there's a real benefit to having more than one blood pressure drug because, as I just mentioned, with those four main classes, they each work in different ways. So it's actually better to take 2 or 3 different types of those blood pressure medications at a lower dose. And then you get a synergistic effect without running as much of a risk of getting the side effects of taking the maximum dose. So if your PCP wants you to take more than one, that is why, and it's actually a really good idea. That being said, the fewer times a day you have to take medicine, the greater chance there is of you being compliant. People are much more likely to take something that's once a day instead of 2 or 3 times a day. But again, we're looking to get the benefit of multiple different ones. So that's my spiel on blood pressure and why it's important. Part of the reason that I suggested doing this is because we had a real spate about 2 years ago of people with palpitations and specifically atrial fibrillation. So I wanted to spend a few minutes on palpitations to, again, let you know when is there a problem and when is there not a problem. Everybody has extra beats, and extra beats are what palpitations are, is they're extra beats coming out from the electrical system in your heart, and it's perfectly normal. Some people feel them more than others. And this is my spiffy. If I'm moving my cursor, can you see the cursor moving or not? Yes, okay. So here is the electrical system in your heart. Your heart is made up of 2 independent but synergistic systems, the electrical system and then the pump system. So this is only addressing the electrical system. Everybody has this little collection of cells up in here called the sinoatrial or SA node. And that's your body's natural pacemaker. It's a microscopic collection of cells in the left atrium, which you're looking at over here is the left atrium, that's the right. It's this little microscopic collection of cells that is with you from the time that you're in utero until the time that you die. And it really is absolutely amazing. And when everything is working the way it's supposed to, which it does most of the time, the SA node fires out an impulse, and it is anywhere from 60 to 100 times a minute affected by different things. The impulse goes across the SA node, across the atrium to the AV node, the atrioventricular node, which is between the atria and the ventricles. And then it goes down a collection of a tight grouping or a bundle. And then from there, it goes on 2 different pathways to get out to the ventricles. And that is happening with every beat of your heart. This is why I got hooked on cardiology so early, because I think it's so amazing that as we're sitting there, generally averaging out 80 times a minute, you are getting this little collection of cells is sending out an impulse. It's going down to the next collection of cells. It's then going down, and that is what is making your whole heart beat. It's absolutely incredible. What's even more incredible is that you are born with backup systems to this. So if the SA node fails, which could be from having a blockage in the blood vessel that goes there, or more commonly, it getting stretched out over time, which again is something that happens with high blood pressure if your heart muscle is getting enlarged, is that little tiny collection group of cells there can get stretched out so that it no longer works. But the body has a backup system for that, because heart muscle is different than any other muscle in the body in that it has the ability to intrinsically generate its own electricity. So when the other little tinier, smaller electrical parts, electrical fibers in this upper chamber, I'm finding that if I don't use that continuously, it stops working for a couple seconds. Throughout this chamber and this other chamber, the other atria, and even into the blood vessels going in and out of the heart, the muscle fibers have the ability to generate their own electrical impulses. So if there isn't an overall commander, which is what the SA node is, sending out impulses, then all of these other little guys say, well, gee, if I'm not getting the chief in charge, the body's pacemaker, telling me I better start sending out electrical impulses. So what ends up happening is all these little muscle fibers end up sending out all of their own impulses. And no one of them is able to stimulate the next part down the line, the AV node, but randomly a bunch of them will get together and that will set it off. But what that does is it means that it's irregular, because all of these little areas, all of these little electrical impulses are just barraging that next thing, the AV node, with the stimulus to beat. And this is normal. This is what's going on, presumably, with all of us right now, that each of that is one heartbeat. So this is where the little hump up here is where it's coming out of the SA node. This little pause there is it traveling to the AV node. And this, the big one up and down, is your ventricles getting depolarized. So that's telling them to contract. And the big hump at the end of it is the repolarization. So it's resetting the system to start all over again. And this is going on every second of your life. And again, I just think it's so amazing. So here is one beat of your heart going from the SA node to the AV node to the ventricles, and then resetting itself in preparation for it happening all over again. And these are two different views. I had in the 12 leads, but I took them out. So this is looking at your heart from two different views. That's why it looks a little bit different if you compare complex to complex, but you can see it's still the same thing. There's a hump there, there's an up and down there, and then there's another hump there. They just look a little bit different. As opposed to, whoops, shoot, where's my atrial fibrillation? Thought I had an atrial fibrillation here. Darn it, darn it, darn it. There it is. As opposed to atrial fibrillation, where, see, you don't have that big pronounced bump anymore. You have all of these little ones. So that is what you're getting from all of those other little muscle fibers up there in the atria firing off. And then at some point, there's enough of them that it then goes through that AV bundle and the ventricles contract normally. So this is the primary backup system to if your body's natural pacemaker fails. But since it takes a collection of them and everyone hitting at the right time, it becomes irregular. And it's irregularly irregular. That's the key phrase for atrial fibrillation. And atrial fibrillation is the second most common rhythm. Normal sinus, which is the first one, which is normal, is the most common. Atrial fibrillation is the next most common. There's a ton of people walking around with this, most of whom are older, but there are some younger people that get it. Interestingly, you can also go into it with alcohol poisoning. So this is what we would call a control rate. This is going to be right around 70 beats per minute. But with those little fibers, as fast as they contract, they can send out 300 impulses a minute. Obviously, we don't want your heart beating that fast, but some will get through faster than others. And again, it's going to be irregular. So here is one that you can see is a lot faster. And this is what we call uncontrolled atrial fibrillation. There's too many of those little impulses going through and it's making the heart beat too fast. And a lot of times when you have somebody coming in who's symptomatic, this is what's going on, is their heart rate is going too fast from the atrial fibrillation. The lovely thing is that drugs slow it down most of the time. You go on the right medicines and it slows it down. But that's what we're looking at on EKG. So again, you see there's no defined bump in before. There's like a little one there, but not enough to stimulate it, but then the rest of it looks normal. So again, this is not meant to make you experts. It's just trying to give you a visual picture of it. So then it goes down the AV node. If everything gets knocked out here, if for whatever reason both of the atria get knocked out and they're not giving out impulses anymore, then the AV node here, this next place in the electrical system on the way down, actually has its own intrinsic rate of 40 to 60 beats per minute. So it will still beat and you will still have enough of a contraction to keep you alive and allow you to function to a certain extent at 40 to 60 per minute. And if the AV node gets knocked out, then the ventricles take over and they have an intrinsic rate of about 40 beats per minute. So what is just so mind-boggling is that there is a backup to the backup to the backup in your heart's electrical system, which also tells you how important it is that from an evolutionary standpoint, that many things were put in to account in order to make sure that the electrical system of your heart was functioning. So that again is the normal one. Let's go on to not quite atrial fibrillation, but premature atrial contraction. And this is, everybody has them. Most of the time you don't feel them. A lot of times if you feel them, it's when you're laying down or you're resting or you're trying to go to sleep at night. Because when you have one of these, there's a little pause afterwards. Because remember when I said that big bump was when the heart was kind of resetting itself? If you have these, so you see, so here's a normal one, here's a normal one, and then all of a sudden you see there's a little bit of difference there, and this one is coming sooner than it's supposed to. There's a little pause because the heart's electrical system is going, wait a minute, have to reset. So what you're feeling is generally not the extra beat, you're feeling the pause after the beat. But this is normal. It's brought on by stress. It's brought on by caffeine. It's brought on by alcohol. Of course, the problem is if you're pounding down a lot of caffeine and you start feeling these and you get anxious about it, unfortunately, it's only going to make it worse. So try to take a few deep breaths. Unless it's turning into a major issue, don't worry about it. It's perfectly normal. My point is on this is, remember I said there's all those collection of other cells that have the ability to generate electricity. It's what we call an ectopic focus is where this other one is coming. So it's just a little collection of other cells that have decided they want to have a voice in the electrical system. And as I said, it is normal. In medicine, you never say never, but it is almost never pathologic. It's totally normal. You'll get more than others sometimes, not a big deal. So that takes us up to the ventricles. So we covered the atria and how important they are. And remember, I mentioned that there is electrical conduction down in the ventricles as well. That makes a bigger statement because not only are the ventricles the largest part in the heart, so therefore they're going to have more diffuse electrical pathways, but also when the electrical impulse comes from the ventricles, it's actually going to go backwards up that pathway. So instead of coming down, it's going to go up. And so it's going to create an issue when it comes up. Sometimes there is a pulse with it, sometimes there's not. I think the best thing to do is just show you what it looks like. So you have the underlying rhythm here. This one is normal, this one is normal, this one. And obviously you can see this great big goober right here that doesn't look like the other three. And that's because this is coming prematurely, hence the P, coming from the ventricles, and it's giving the heart a contraction whether you can feel it or not. It might not give a full pulse beat, but you can see it's really obvious, it's really big. These again are very oftentimes very normal. A lot of people get them. Same things can cause them as far as stress and too much caffeine. There's also some drugs that can bring this on. And most of the time, they're not a problem. You can see that all of the ones in this EKG look the same. And that's because there is one place up in the electrical system. So we'll just pick right here. There's one little cluster of cells here that has decided to send out an extra electrical impulse. And because it's from the same place, it's going to look the same. So that's why all of those look the same. I've had people that you hook them up and they're having these every second, third, or fourth beat, totally unaware of it. Perfectly normal for them. When we get excited about it is when you start having more of them in clusters and they're coming from different places. So this one you can see is, see there's that one there and that doesn't look the same as those two, and those two are coming together. And then you have this one and that one, and you've got that one that isn't entirely normal. So this type we get more excited about. This one happens to be from after a stress test in somebody, that their electrical system got a little bit overwhelmed and started throwing out a bunch of these ones from the ventricles. So that, in a nutshell, is the electrical system. With the atrial fibrillation, and just a little bit more on that, again, it's being generated in the atrial muscle. They will just start firing off randomly, and it's kind of an all or none principle, but they're not all doing it together. It's generally described as a bag of worms, that if you look at the atria, you see all these little individual muscle fibers contracting. You don't, as an aside, your atria contract. That's part of what makes the blood go into your ventricles. When you're in atrial fibrillation, you lose that contraction, which is approximately 30% of the heart's output. So if you lose that suddenly, it can make you symptomatic. A lot of people go into it gradually and they don't even feel it. And as I said before, it's irregularly irregular. So the take-home message on that, because I know that was a ton, is your heart has an incredible electrical system that has backup on backup on backup. Having extra beats is not abnormal. The ones that come from the top are generally very well tolerated, as are the ones from the bottom if there's only a few of them. But if you're getting it a lot, if it's irregularly irregular when you're checking your pulse, if it's just kind of going did it, that's when you say something. The other thing is, if you're feeling symptomatic, are you all of a sudden overly fatigued? You're getting out of breath. You climb one flight of stairs and you kind of have to stop in the middle of it. That's when we know that it needs to be treated. A lot of people tolerate this perfectly well, but that's when it needs to be treated. The other thing is that when the body is in this, if you're in sustained atrial fibrillation, which means you stay in it, and you have lost the ability of the atria to contract together, and you've got all of those separate little muscles going like this, it means that you can develop blood clots. So that's why people on atrial fibrillation are also on blood thinners, because you don't want to have blood stagnating in here, because there's not a coordinated squeeze. It's just kind of this all over sort of stuff. And that's why somebody in constant atrial fibrillation will also be on blood thinners. I know that was a ton of information. Any brief questions to clarify? You're probably just too stunned. Again, very briefly, as far as high cholesterol, fatty substances, cholesterol and triglycerides. Cholesterol molecules are larger and are basically tiny little fat globules going through your blood system. Triglycerides are tinier little fat globules that are surrounded by sugar. So those are going to be higher in diabetics. If they are deposited, they can get deposited in the walls of all of your blood vessels, most especially your arteries. And it happens in any artery, not only the coronary arteries that everybody talks about, but also in your carotid arteries, that are the way that your blood gets disseminated up into your brain, as well as your peripherals, i.e. going down into your arms and down into your legs. So this one I spent a little bit more time on, since we blew through electrical. So here, going back to your long ago biology classes, here is how your heart is seated in your chest. It's pretty much under the breastbone, and then it goes over to the left. It's about the size of a man's fist. That can vary as to the size of a person's body. We call this the anterior aspect, because that's at the front of the heart. This under here, the ones in blue are the pulmonary arteries. This is pulmonary vein, actually. This is pulmonary artery that's going into the atria. The blood comes in on the right side, goes through the right atria down to the right ventricle. It then goes out into the lungs in order to be oxygenated, and then it comes back into the left atrium and the left ventricle, and then from there goes out into your blood vessels. So that's just identifying the different basic areas. this is what's called a netter illustration. This was a doctor, a German doctor back in the 1930s, 1940s, who specialized in drawings of body system. He's considered, and we still use them today. This is what everybody likes to talk about because these are your coronary arteries. So even though your heart muscle is beating blood inside of it, that blood inside of it is not going to feed the muscle. And like every other muscle in the body, the heart muscle needs a blood supply in order to work. And this is the system that is giving the heart muscle itself the blood. There's what's called a left main or a left coronary artery coming off here, also known as the left main, and then there's another one coming off to the right. And then they break off to, and basically I compared last time talking about a tree in comparing the lungs. This would be like thinking of it as a bush. So you have the trunk of it, and then you break down into branches, and then all those little branches get smaller and smaller and smaller. And the blood is coming out here. This is actually from the aorta, right above the aortic valve, and it's being put into these coronary arteries, and then it goes through the coronary arteries, and it's giving oxygenated blood to all those different areas of the heart muscle. This is the opposite view, looking at the kind of the bottom surface that's resting more on your diaphragm. The blue blood vessels, as you might guess, are the veins that's taking away the unoxygenated blood. The important thing to remember here is that when somebody has a heart attack, and that means that if somebody's had a heart attack or an infarction, that means that the muscle that was supplied by that blood vessel has died. And as in real estate, everything depends on location. So if you have a blockage of the blood supply down here, so say you get a blockage right down there, the only part of your heart muscle that's going to be affected is the part that area is giving a blood supply to. So that's not going to affect you as much as if you get a blockage up here that's going to affect all of this heart muscle, or even worse, if you get a blockage up here that's going to block it from going down two of those major branches. Again, not meant to make you an expert, just trying to give you a quick overview of why it's important. So I don't know whether Scott's joined us. I was talking with him about this. The endothelium is one of the most important things in the body that nobody outside of mostly cardiovascular people care about. The endothelium is this very, very thin layer of tissue that is the separation between your circulating blood and the blood vessel itself. And I describe this like tissue paper. So picture, like that white tissue paper that is always wrapping up things. Picture that as the lining that is between the blood that is circulating and your heart muscle itself. The key thing about the endothelium is that if it is broken down, if it is damaged, that's what allows the circulating cholesterol to get into the wall of the blood vessel and start building up plaque. So damage to the endothelium, then this is one of my favorite quotes, initiates a cascade of events that allows to the buildup of plaque. And that's what people are talking about when they talk about having blockages in their arteries. And the things that damage the endothelial lining, high blood pressure, diabetes, sugar is very damaging to that endothelial tissue. Carbon monoxide, and that also includes the smokers, the damage that those chemicals are doing. Radiation damage, women who have had breast cancer and have had radiation to their breasts can have a breakdown of that endothelial wall. Sometimes there's just familial genetic factors, inflammation, and there has been a theory for years that there is something of a viral component that could damage that endothelium. Going back to the inflammation, this ends up being a much bigger player than we realized even 20 years ago. When people started getting put on aspirin, pardon me, the theory was that it was to keep the platelets from sticking together. But what we found over time is that it's also decreasing inflammation, and that's keeping that important endothelial lining in place. As a current aside, when during COVID, when it started coming out that children were getting sick with what they were calling this diffuse vasculitis, this diffuse inflammatory condition that was in their blood vessels, I said as soon as I heard that, it's damaging the endothelial wall. And now if you Google that, you will find it, that inflammation the virus was causing was damaging the endothelial tissue. So it was breaking down one of the most important protective things for all of the blood vessels in the body. So that's why this endothelial tissue is so important. So that again is why you want to control your sugar level, because sugar affects it, why you want to make sure your blood pressure is under control. You do not want to lose that endothelial tissue. So this is one of my favorite slides from the standpoint of you get a vascular injury to that endothelial tissue that then allows the plaque to start building up. And over time, you will see that it develops this kind of white fibrous cap on it. This is what happens when it develops very slowly. Some people, however, and younger people, will get one of these that builds up much more quickly, and the cap on it isn't as secure. And for some reason that we haven't figured out yet, at some point that plaque can rupture open. And so it then puts all of this yucky, junky, picture chicken fat stuff into a blood vessel, and that's what ends up causing it to block off, because then all the platelets rush to try to fix the fact that they're reading there's a broken vessel, creates a blood clot, and that's what ends up damming up one of your blood vessels here that will stop the blood flow from going down to the heart muscle. So here is a cross-section of a healthy coronary artery. So you can see it's nice and pink there. You can see there's a nice big lumen or space where the blood is going to be flowing. And here is one where you can see that plaque just sticking up, that big honking piece is sticking out. Obviously, it's going to be blocking up how the blood is flowing. And you can see, looking back further, this is the body's natural vessel wall. And you can see that there's all this taking up space. So it's going all the way around, which has significantly decreased the amount of space that there is for blood to go through. I know this is really fast, so maybe at some point I'll have to break this down and go over several weeks because this is a lot. So when you get that blockage, when you get one of these plaques that ruptures open, when you have this blockage in that blood vessel, that means that the muscle below that area is not getting as much oxygen as it needs. And it's especially when you're exerting yourself. When you exert yourself, your heart rate goes up because your muscles need more oxygen. The heart has to work harder. So you climb a flight of stairs, but because you've got narrowing of your blood vessels, not as much blood is getting through and not as much oxygen is getting through. And you end up getting pain in your heart because of that imbalance. So it's a supply and demand variation there, that the supply cannot meet the demand of the heart muscle itself. And the classic presentation to this is getting pain or pressure in the center of your chest because it's coming from the heart muscle itself hurting because it's not getting enough oxygen. Radiation to either side of the jaw, more commonly the left side, radiation down the left arm, because remember the heart is skewed over towards the left normally. Happens when you're exerting because your heart muscle needs more oxygen and it can't get it. It's relieved with rest or taking nitroglycerin, which we won't get into, and can also cause shortness of breath and that feeling of nausea. So this is what you see when you're watching television or the movies, and all of a sudden someone dramatically clutches their chest and falls to the ground, and oh my God, they're having a heart attack. If this was how everybody presented when they were having angina, which is what can lead up to the heart attack, it's telling you when there's a mismatch, it's telling you there's a problem. If everyone had this constellation of symptoms, we would save a whole lot of lives. Unfortunately, not everybody has these classic symptoms. As a matter of fact, even somebody that is actively having a heart attack will only have these classic symptoms 30% of the time. And I touched on this last time, that means that atypical symptoms actually should be renamed to more typical symptoms. And they include, and we're going to do angina first. So angina is the heart muscle saying, I'm not getting enough oxygen, but it's not damaged yet. So it's giving you a warning that there's blockages, that it's not getting enough oxygen through. And that is going to present, especially with exertion. And the big one here is dyspnea, which is getting out of breath with exertion. So as I said 2 weeks ago, climbing the stairs, especially climbing the stairs holding something. The classic is coming up from the basement with laundry. The other classic is snow shoveling, that you hear about them saying, you know, don't go out and shovel, especially if it's that heavy wet snow, because what happens when you're exerting yourself, the muscles in your body need more oxygen. Your heart tries to comply by giving more of a blood supply with oxygen, but there's a blockage that it keeps it from getting as much blood flow. And so the heart says, hey, I'm not getting as much oxygen as I need. And if you don't get the pain, or you can get pain and getting out of breath, and you can also get extreme fatigue, that, you know, you go out, you do the snow shoveling, and boy, you just do, you know, 5 shovelfuls, and wow, oh my gosh, I just can't go on anymore. That can be an anginal variant of the heart saying, I'm not getting enough oxygen to be keeping up with what you're asking me to do. It can also present with epigastric pain, so that the feeling of heartburn. If you're getting heartburn when you are exerting yourself, chances are it's not heartburn, chances are it's angina. There are some people that just get nauseous with exertion. They'll get more palpitations with exertion. They can get back pain, neck and jaw pain. I've seen some people with heart attacks, all they have is, well, I've been getting this toothache, and I notice I get this toothache anytime I mow the lawn with a push mower. Arm or shoulder pain with exertion. And what this boils down to, if you take nothing else away from my very quick talk here, any symptom that happens consistently when you're exerting yourself is angina until it's proven otherwise. So if every time you go out to mow the lawn, you're getting this pain in the middle of your back, and you sit down and it goes away, and you get up and you try to do a little bit more and it recurs, or if you are getting pain in your jaw every time you're out raking leaves, and you stop and it goes away, and you start and it comes back again, that is angina until it is ruled out. Is that description of things always angina? Absolutely not. You can be having a muscular spasm that's causing the pain in between your shoulders because you're using your arms and your shoulders to be moving the leaves or moving the snow or pushing the lawnmower. But the muscular cramp is not going to kill you as quickly as if it's angina. So if you're getting symptoms, and this is something that the patient needs to be able to tell the practitioner, and it's one of the things that's the main thing that we ask. And the other thing is, how long has it been going on for? And I used this example 2 weeks ago. If you could run up the stairs, 2 flights of stairs 3 months ago without a problem, and now you have to stop in the middle of the stairs, you can't get to the end of the stairs, and it's only been a month or 2 months since you could run up the stairs, we're really concerned about it. What we are not as concerned about is, gee, I can't run up the stairs like I did 20 years ago. 20 years, we expect that you can't run up the stairs quite as quickly. 2 months ago, we get a little bit more concerned. But if you remember nothing else, if you get any symptom, I don't care if it's a numbness in your hand, any symptom that happens consistently when you exert yourself, Your heart needs to be ruled out as a problem with blockages in your heart vessels. And until that is ruled out, that's what our presumption is. And one of my better examples on this, as far as the importance of it, is several years ago, we had a young kid, and I'm talking 23 years old, had been a runner all through high school, did track in high school and college, obviously continued to run, started getting chest pain when he was running. Father was concerned, took him to a cardiologist. They said, yeah, you're 22, you're 23, it's not a big deal. Fortunately, the father wasn't happy with that, brought him to our group, where the cardiologist said, well, it would be really unusual, but if you've been consistently getting this, then we need to make sure that it isn't a blockage. And son of a gun, this 22-year-old kid had a 95% blockage in his heart artery. Why did that happen? We don't have an explanation for that. But the point being, consistent symptom that's happening when you are exerting yourself. And that includes, like, one time it was when you were raking, and one time it was when you were shoveling snow, and one time was when you were running up the stairs. If you're getting the same symptom with all of that, that falls under this category. And that means that you're getting this buildup here, which is keeping the heart muscle from getting as much oxygen as it needs to it. And again, the symptoms that you get, there are variations in symptoms, a lot more stomach ones if it's on this side of the heart than if it's on the other side of the heart. And again, where you're getting where the blockage is going to have a huge, is going to affect the outcome. It's going to affect how severe the symptoms are. And it's also going to affect treatment, because if you get a blockage down, let's say you've got a blockage that's affecting these three little tiny ones, we're only going to put you on medication for that, as opposed to you've got a blockage in one of these larger ones that is giving oxygen to a much larger area. We're going to be treating that differently.
What happens if a vein in the heart gets blocked, or doesn't that happen?
It doesn't happen as much, because generally all of the things that are affecting the endothelial tissue are happening in the arteries and not the veins. It's not impossible, but it's incredibly rare. It will be the artery that will be the ones that are going to be affected the most. Anybody else? All right, then. Boy, I am talking fast because I didn't know we'd get down to this. So when you get sent in for a nuclear stress test, I just thought, I'm a big visual person. So what happens is the nuclear material that's used for the stress test is taken up into muscle. And then we can take pictures of where the nuclear material is, and therefore infer where the oxygen is. So it actually attaches onto hemoglobin, but since hemoglobin is what carries oxygen molecules, if you know where the hemoglobin is, you know where the oxygen molecules are. So these are pictures from what we're looking at when we're looking at the nuclear material being taken up into your heart muscle. So you'll see over here, it says it's labeled stress rest, and that goes all the way down, stress rest. So there's two sets to each of these pictures. So let's look at this, let's look at the middle one. So here is the basic, this is what is happening when someone's at rest. So you can see there's a great big horseshoe, and we're looking at the left ventricle. And this is after exertion. And you can see there's not much of a difference. So this is, the little part starts at the apex of the heart and then moves up. And then they do side slices to be looking at the ventricle. The left ventricle is the most important of the four ventricles, because that's the one that squeezes the blood out. That's as opposed to this person who you can see very dramatically. So this is how the oxygen distribution, and therefore the nuclear distribution, was in his left ventricle at rest. And then we stressed his heart, whether it was through drugs or putting him on the treadmill. And all of a sudden you can see it's not lit up the way it is. So this would be showing a nuclear stress test, showing a severe blockage in his heart vessels, that there's not there's very little blood supply getting through. So that's just to give you a visual for what we mean when we say they failed their stress test, is we're actually looking at how the blood is, the oxygen is being taken up into the heart muscle itself. So we've determined that, for example, this poor guy definitely has heart blockages. Let's see what we're dealing with. The next thing is going to be a cardiac catheterization. These used to be a big deal. Last 20 years, really not a big deal. A lot of times if somebody is getting a catheterization and they don't find anything, they're discharged the same day. You don't even get admitted overnight. Cardiac catheterizations are fabulous. They're both diagnostic and can be therapeutic. You can take a look at the lesion itself. They can even do an ultrasound of your blood vessels to be looking on the inside. 99% sensitive, we never say 100%. You can also assess the valves in there, which I'm not going to go into, and the pressure in your heart. The left ventricle, as I've said a few times, is the most important it's the most important one of the cavities in the heart. Because it's responsible for squeezing, we get the best chance of looking at what that looks like on the inside. And not only can we see everything that's going on, a lot of times we can do something about it. So cardiac catheterizations more commonly used to be done up through the femoral artery. So if you put your fingers down in your groin, and you might have to move it around to get to the right place, you will feel your pulse down in your groin. So what they're doing is they're going to thread the catheter. They make a little incision. I'm talking like an inch. And then they thread the catheter through the artery, and then they can go up through the passageway of the blood vessels and then be looking into the heart. They can also, right alongside it is the femoral vein. So sometimes they go through both the vein and the artery so they can see both sides of the heart. What they started doing more commonly about 15 years ago was, instead of going through the groin, which, and speaking from experience, you feel it for longer, for the next couple of days when you're walking, you just kind of feel something strange down there. So they started, once they got smaller catheters, they started going more commonly in through the wrist. Still ends up in the same place because all blood vessels eventually go back to the heart. It's just another way of accessing. So it used to always be femoral. A lot of times now you'll hear radial. In a lot of ways, it's almost the same amount of shot as far as the distance that it has to go, but it's easier for somebody to have it in their wrist than to have it down in the groin. But it either way will make the diagnosis. So this is, they actually put the catheter in, and it's very flexible. It bends, and the physician who's doing it can kind of move a little bit to go around corners and bends. And they will then fish it through. Remember the other pictures, the Netter drawings. They're going from, here's the aorta, they're going down into, this is going to be the left main, the left coronary artery. So they're actually, and left anterior descending is the most important one, because it is what gives blood supply to the greatest area of the left ventricle. But they actually fish this down through, and on that catheter can be a balloon or a stent, which I'm about to show you pictures of, but just terminology. Percutaneous is going through the skin. Transthoracic is going across the chest cavity. Coronary, obviously, in your heart. And it can be just taking pictures, which is the angiogram, is shooting dye in and taking pictures, or angioplasty is when they use the balloon. More commonly now, it's called an intervention. So it's just kind of an umbrella term. So this is using an ultrasound that's going through the catheter. This is the blood vessel. This is the coronary artery. And you can see all this yellow, yucky plaque that's building up. And that is the only space that the blood has to move through. So they put one of these catheters in, and they have a gizmo on here that is able to develop or deliver a stent. And I'm going to show that again in a second, but that shows you how tiny it is. We're dealing with 2 and 3 and 4 millimeters. and they put a stent in, and if you can see, it's partially blocked by, in my view, by your pictures on the side. But see this kind of like brighter white stuff here? That's the stent expanded, and you can see how much larger the opening is now that the blood can go through. So this is what they're doing with an intervention of, they're taking something with all of that yellow stuff that's blocking up, that's restricting the blood flow, and they're using this, and they're putting in a scaffold to be squeezing all that stuff to the sides and make sure that it's going to stay open. It really is incredible. And this is another view of looking at it. So this is demonstrating what would happen with a blockage. So they're showing, and this ties back into one of those other slides I showed you. So here's the plaque, and you're looking at this, and you can see that's maybe taking up 30% of the blood flow. You've still got way more than 50% going through, 70% of the blood going through. Everything's fine and dandy. This person might be getting some angina if they really exert themselves. They're, climbing a mountain for a view, and they'll get pain, but they're probably functioning pretty well. Right up until, for some reason that we can't figure out, this plaque buildup there ruptures open. And the body cannot tell a difference between the platelets that block up blood vessels when they're open. They can't tell the difference between the rupture of this, which is internal, or if somebody cut through the actual blood vessel. They do the same thing regardless, which is they rush fibrinogen and platelets to try to block up what the body is perceiving as an opening. And what that does is, on top of having all this yucky yellow stuff that's been released in there, this massive amount of fat in a fairly small amount of space, it also builds up a clot. So that's the occlusive thrombus. Thrombus meaning the clot, and it's occluding. So now, instead of the blood flowing down through, now the blood is not able to go through. So everything below that area is not getting muscle. Now, this actually holds true in any artery in the body. So we can stop here right now with those two. This can happen in a leg artery, and more important, this can also happen in a brain artery, which obviously then means you're not dealing with heart muscle, you're dealing with brain tissue, but it's the same premise that you have something that obstructs the blood vessel, the blood can't get through, so everything below that blockage is deprived of blood, and that therefore it's deprived of oxygen. This one, we're looking at the heart, so they're showing you the two views here. And remember, so here it was where, and I had said that this person is probably functioning pretty well. That's where we're showing the blockage. Now we have that thrombus, and you can see they're showing that there is no blood that is getting through to any of that blood vessel in there. So they thread the stent through, and as they say, they have a deflated balloon here, and then it would also have the stent on top of it. And then they blow up the balloon, and they squish all that stuff to the side, and there you go down here with your going from, there's the catheter going in, you're now going back to having blood flow. So when somebody is going in for an angioplasty, when they're going in for a catheterization and they find a blockage, this is therapeutically what they're doing. And it's dependent on who you go to. The catheterization guy in the practice that I was with was actually world renowned. He was a gift of God in that man's hands, that he could manage to get through places nobody else could. But this can fix the problem. So that means you go in for catheterization, they find the problem, and they can fix the problem while they're in there. It can be done urgently, because obviously this is going to be an urgent situation. Or it can be that if you imagine this plaque is building up and building up and building up, and there's still a little bit of flow getting through, that can be done at not as urgently. So that doesn't need to be done at 2 o'clock in the morning. This one needs to be done at 2 o'clock in the morning. But in any case, what is happening is you are opening up a vessel that was either partially blocked or fully blocked, and you are opening it up so that you can get blood flow freely flowing through it.
Well, how long can somebody last with the situation you're just showing in the second picture where it's completely occluded? I assume that suddenly
That boils back again to location, location, location. They're showing it up here really, really high in the artery, which again means all of that muscle tissue. And if you look carefully, you can see that they've changed the color of the muscle tissue here. So see the difference between this muscle tissue and that muscle tissue. So they're indicating that that is not getting oxygen. That's going to be a much bigger deal than if it's happening down here where it's not affecting as large an artery, where that blood vessel is not giving blood supply to as much. But again, in the incredible backup systems that the heart has, a lot of times, and if we go back to that initial blood vessel picture, if you look at this, so let's say that you have a blockage right here. So that would be just about midway down in the blood vessel. It's not, so it's going to blow, let me make it a little bit lower. So let's say you've got a blockage right here. So that's going to affect what's below it. However, there's a certain amount of oxygenation that's going to be coming down from this blood vessel that's above it. That's this blood vessel that's coming from another artery that's wrapping along behind it. The blood vessel's coming over here. So that's part of what buys someone time, in that because the heart has so many backup systems, that even if you have a blockage in one area, you might get permanent damage in that immediate area, but there will be at least some blood flow to the other areas because there's so much redundancy. That was the word I was going for, redundancy. Does that make sense?
Yep. Now, how does this relate to bypass surgery?
You led up to the next slide.
Oh, okay. My father had quintuple bypass
surgery. Okay. So, and that's part of why I did this, because you hear these terms all the time, but what's the difference between the two of them? Just to go back as far as this, it is amazing anymore how many of these stents they can put in. There are some times when they will put in stents. You've got somebody with really, really diffuse blockage that's going down here. This is the most important artery. And they will have stents that are just going one right up against the other. They have to be in descending size because you can see the blood vessel gets smaller and smaller, but they can fit like 4 stents in one of these blood vessels to be opening it up all the way. And they're doing that more, probably about 10, 12 years ago. They started doing that more and more because the technology was getting so much better. The stents were getting so much better as far as how much space that they took up in the blood vessel, not reblocking again. And it's always better to do something that's less invasive than something else. So a lot of times people might be getting stent, and not need bypass. But especially, when did your dad get the bypass graft?
I think it was 1999.
Okay, that was when they started doing more stenting, especially in the early 2000s.
Okay.
But that is, so coronary artery bypass grafting. The old way of doing it was they would take saphenous vein grafts. So that would be taking veins from your legs that had redundancy. Now, again, if it's a vein, it means that it's carrying the blood away from, in this case, your feet. So that's not as critical as what's carrying the blood down to your feet. So they would take a portion of your leg veins, and they would be using that for grafting material. But what they found is that that involves 2 areas of incision, because obviously you have to make an incision in the leg to do that. And they also found that a vein, which, remember when Susie asked about, do you have to worry about blockages in the veins? Veins really are a different animal. They don't have the musculature that arteries do. They also don't have to handle the same amount of pressure that arteries do. And they found over time, with people living longer and longer, that when you put a vein in a position that an artery should be, the veins simply could not hold up over decades. Now, did that matter a whole lot if it was somebody who was in their mid to late 70s or early 80s, that their vein graft was gonna wear out? Chances are not. But if you're dealing with somebody who's in their 50s or 60s, chances are that vein was not going to hold up. So they started doing more with arteries. And you have, and I do not have a picture of this, but you have in your chest, right around your clavicle area, and below that, you have what are called mammary arteries that are what's supplying blood to the chest wall. But again, because arteries have redundancies, they can take out those mammary arteries, or they actually take out one end, and I'll get to that in a second. And they can graft that into the heart artery. And then they started doing radial arteries. There's a caveat with that. There is about a 10% loss of fine motor control if they on the side that they take the radial artery from. So obviously they would take it from your non-dominant side. But the one that I always think back on is we had one of the other practices, absolutely fabulous gastrointestinal doctor who did a lot of colonoscopies and a lot of surgical repairs. He had to have bypass grafting, and he said, you can't do a radial artery on me because I can't lose even 10% of my fine motor skills. But most of us could lose that from our non-dominant hand. And again, you're putting an artery into where an artery was in the past. So what does it mean that you're going to be bypassing on, or how are you going to get there? The old-fashioned way was the sternotomy, where you cut down the breastbone and then you separate the breastbone and the ribs, and that's how you go in. Again, speaking from personal experience, it's really not a lot of fun, and it really, really hurts for a long time afterwards. So they started doing these minimally invasive ones because, again, the catheters were getting so much more advanced. What they can do with catheters now is absolutely amazing. And actually the technology is what then crossed over into gamers. But if you picture the difference in what you can see in the computer games of the 1990s as opposed to computer games now, that technology is mirrored in what can be done in the catheters that we're using and the ways that we visualize inside of body cavity. So they can now make much smaller incisions. They can make incisions in between the ribs instead of going in through the breastbone. So there's other ways to be accessing, to be getting in to fix these things. The other big thing that you'll hear about is whether it's on or off bypass pump. I'll take a breath here to describe that one. It's really difficult nomenclature in that there's two different bypasses. You can be bypass pump while you're getting a heart bypass. It's unfortunate that they are the same word. So being on a bypass pump means that they have to shut off the blood supply to the heart in order to operate on the heart. Obviously, stopping somebody's heart is going to create a few problems in a lot of other places. So what they do is they actually bypass the heart. They put in other larger size catheters. They'll put one in the aorta that's coming out of the heart. They'll clamp off there and put a tube in, and then they'll do another one going up through the groin and clamp off the one that's going up into the heart. And they will then run tubes into a machine that does the work of the heart. It's bypassing the heart, and this bypass machine pump does the work of the heart. It does the oxygen exchange, because that also means it's not going through the lungs. It does the oxygen exchange. It takes out the carbon dioxide. It does all the things that the heart does. And that enables them to stop the heart entirely so that they have a surface that is not moving at all, which you can kind of guess. If you don't have a moving target, it's a lot easier to do things on it than if you have a moving target. The problem with that is, of course, that you can have problems on the bypass pump. They're still not entirely sure what causes the neurologic changes. They think part of it is the damage that it does to the red blood cells, but it is very common immediately after coming off bypass, and for some people longer term, that you can get neurologic brain side effects from being on the bypass pump, because nothing is as good as what you have naturally.
Yeah, that's what happened to my father.
Yeah. Well, it happened to me. And they developed this thing called off pump, which I'll get to the next slide and give a better demonstration, that there's a way that they can clamp the blood vessel that they're working on that can shut off all but the tiniest amount of blood going through, and they can fix what they need to fix there without stopping the heart and putting them on the bypass pump. And that is highly preferred because, but as with everything else, there's pros and cons. Won't get into that unless they ask. So here is what a bypass graft actually is. So we're going to say that this was taken from the radial artery, or it was taken from the leg vein, and they actually punch a hole in the aorta, which is the big blood vessel coming out of the heart carrying the oxygenated blood. They punch a hole in that and they suture one end of it. And then the blockage is clearly here. They punch a hole in the blood vessel below where the blockage is, and they sew the other end of the bypass graft into that. So now you have freshly oxygenated blood coming out from the aorta and being taken down to that blood supply, which is to that blood vessel, which is supplying all of that heart muscle. It is bypassing, therefore, the blockage that is, for example, right there. And the nice thing about if they do an internal mammary, which I don't have a picture of, they actually don't have to do this part. They can take an internal mammary gland and leave it attached and then just sew it into the coronary artery. So that many less holes to suture. Now, what did I have after that? All right, so does that make sense now?
Yes.
Or at least more sense than it did? All right, forging on then. So I mentioned before, there's angina, which is a oxygen supply demand mismatch, that the heart muscle is not getting as much oxygen as it would like. The demand, the supply that it can give does not meet the demand that's being put on it. And so you get angina, which is the heart saying, hey, excuse me, I'm not getting as much as I want here. That is different from an infarction. An infarction is actually tissue that dies because it's not getting oxygenated. So this is a myocardial infarction or a heart attack. So that's why there's a huge differentiation between angina and heart attack, because if you say that somebody has a heart attack, you are saying that a portion of their heart muscle has died, dead, not coming back to life. So there is an area that is not working anymore. It can be a really, really tiny area, or it can be a bigger area. But it's a permanent damage due to the occlusion of that coronary artery, secondary to clot, pressure, spasm. So it can be that clot, that thrombus that you saw before. It can be that plaque rupturing open and causing that blood vessel to get blocked off. Or if you have a long enough sustained spasm that the muscular artery walls clamp down so hard that no blood gets through. There are some congenital issues that give this. The one that you hear about it more is cocaine. This is what causes cocaine infarctions. Cocaine causes blood vessels to spasm. And if it goes on long enough, it can give permanent damage to the heart muscle. So this is, I love pictures. So this again is that all important endothelial tissue. This is when it has ruptured open and you've got platelets. These are red blood cells. Platelets are teeny, teeny, tiny. And all of this is now taking up space in a blood vessel. And this is a picture of the difference between heart muscle that is dead and heart muscle that's still alive. And you'll notice on this, while this one seems to be all dead, part of the muscle here is dead and part of the muscle fiber here is alive. So this part of the muscle fiber was getting oxygenation from another blood vessel that was nearby. So that's why that muscle fiber is still working, and why this one was not. So again, I'm going for a visual as far as this is the difference between heart muscle fiber that is dead and heart muscle fiber that is still doing okay because it had ancillary blood supplied to it from another blood vessel. And symptoms very similar to angina. They do tend to be worse. People that had angina and then have a heart attack say, yeah, this is definitely worse. Again, chest pain, chest pressure, heaviness, or a squeezing sensation. The classic description is, I feel like an elephant is sitting on my chest. It can radiate to either arms. It can radiate up into the neck. It can radiate through to the back. Shortness of breath. It can make you feel nauseous. You can be vomiting. There are some people that we've seen come in that think they have a GI bug because they get nauseous and they're vomiting and they're breaking out in the sweat, and they don't realize that it's more than that. They can get rhythm abnormalities. They can go into heart failure, and of course, the thing we're trying to avoid, sudden cardiac death, where there is so much of the heart muscle that is affected that the heart just can't function anymore. Interestingly, as far as that goes, you can have the heart pump part of the muscle stop working, and the electrical system will still keep going for a while, which is why those two systems are separate, intertwined, dependent on each other, but they are separate. You can also have the electrical system get knocked out, and the pump can still go for a short period of time, although not very long. Okay, it is 20 after 6. I did warn you it was going to go long. So after that exhaustive amount of information, I'm going to stop sharing now so I can see your faces. Questions?
Laurie, 2 questions. That endothelium, the lining, once that breaks down, does that ever rebuild itself or repair itself? No? Okay. And you had mentioned like taking the low dose aspirin, and somehow I thought the pendulum had swung on not doing that. What is, like, the cardiac specialist feeling on that?
That's one of those ones that I will sidestep because I'm not giving medical advice by saying. It is determined on several factors. It's determined by whether or not have you had any recent stomach bleeding. That would be a reason to not be on that. Do you have an underlying condition that is already affecting your platelets? Interestingly, and they're still investigating this, the protective effects from aspirin work better for men than they do for women in the first couple of years. They're not entirely sure why. It depends on other risk factors. It depends on what's going on up in your brain. So it's very common. And there's a lot to be said for it. And a lot of times they'll say take one 3 times a week, not every day, and then you can ramp up. Interestingly enough, the component of aspirin that affects the platelets will tag itself onto a red blood vessel for the entire life of that red blood vessel. So a fresh red blood vessel will last 120 days. But that means that when that red blood cell has gotten to the end of its life, it loses that effect. But if you're still taking aspirin, it's going to be tagging on to the newer ones. So there is not a cookbook answer to that. There's other things that affect it, and again, women for some reason, especially women who are perimenopausal, do not seem to react as well as men. Men generally react better to aspirin. However, women, as they get older, it then creates a protective effect. So it's not a straight black or white answer.
Okay. And Bill had a question. He's on my computer downstairs, but he has a sore throat and he can't really talk. So, oh gosh, now what was it? He came up and he told me to ask it. When you have a catheterization, there he is. What prevents it from like breaking through the artery or the vein?
How good the cardiologist doing the study is. It does occasionally happen. It's very rare. We're talking way less than 1%. It's like 0.01% of the time that, yes, that's one of the things when you're signing the disclaimer form. Is one of the things that can happen. But I will tell you, in all of the on-call that I did for a very busy cardiology practice, including an invasive guy that was cranking out literally 5 and 6 catheterizations a day. There was only one time that happened when I was on call. So can it happen? Yes, it can, but it's very, very rare.
Then what do they do?
At that point, it depends on how big it is, and it also depends, again, on location. If you burst through in one of those arteries that is further up the chain, it very well could mean emergency heart surgery. If it's down in one of the smaller ones, a lot of times they can go in with a catheter again and block it off. Inflate a balloon and leave the balloon inflated for long enough that it doesn't leak anymore. So it depends on where it is. So I cannot stress enough the importance once you start getting into the vasculature of the location. Big part of the vessel, more of a problem than the small part of the vessel.
I remember back in the late 1990s or whenever the stents were first coming out, my stock investment club was checking out which companies to invest in. They were worried about clogging, like that they would cause clogging up much faster and it wouldn't last long. Now, is that dealt with blood thinners, or what happens nowadays? Why is it not so much of a problem you're mentioning?
That is an excellent question. And again, you're dating yourself from the standpoint of when you were dealing with it. When they first started putting in stents, which are still called bare metal stents, what they were finding is that the body was looking at it as a foreign object, and it was doing what it does with foreign objects is it started to, bye Scott, it does what it does with small foreign body objects, and it would actually start coating with scar tissue over that stent, which over time could end up blocking it up just as much as it was before the stent went in. So that led to the next generation of stents, which they developed a coating which kept that from happening as often. And if you've talked with somebody who's had a stent in, they will be on a class of drugs that decreases that scar tissue formation even further. So that, and generally that's taken for 3 to 6 months after the stent is put in. And then by that time, the body's gotten used to it and doesn't develop that tissue over it. Interestingly, because all of those, you're also going to be on blood, a different type of blood thinner, and it'll be more of a platelet aggregator. They do still use those bare metal stents in situations where, and I've seen this happen, somebody is getting a stress test before they're getting surgery for something else. The one that has always stuck in my mind is a woman that was going in for renal cell cancer and was going to be having a kidney removed, had a stress test beforehand. We found a major blockage, which meant that she probably wouldn't survive being on anesthesia for the kidney being removed. And I think they were going to be doing something else, obviously biopsying other things. So she was somebody that got one of those bare metal stents in because she didn't have to be on the blood thinner then, so that they could go in and take the cancerous kidney out. And then she had to go back in again for another type of stent. So again, not a cookbook. It very much varies, and there's, it's a bell curve. Most people fall in the center and going out of the bell curve, and then you always have those people at the end that have these different things.
Now, my mom has, I'm sorry, I keep asking questions, but other people are welcome to chime in. My mom, got a pacemaker in 2018, I think, at age 93. And what vessels, it seemed like it was all surface, but did they go into the heart for that?
And I just want to tell you, I think this room is only booked until 6:30. And so if we get cut off, I just wanted you to know that if I stop speaking in mid-sentence, that was why. Yes, they go in through the vessels. It's really cool. They just create kind of like a little pocket, and then it's just wires that are going into it. And it's actually, depending on where she needs it, and depending the reason why she was getting it, they can put wires in both of the atria. Sometimes it's just the left atrium where the body's natural pacemaker was, and sometimes they also thread another 1 or 2 down into the ventricle. So again, there's a lot of variables on that.
Okay.
Anybody else?
Very thorough for the time frame and for the
Yeah.
expertise level of your auditors. Thank you.
Thank you very much.
You are very welcome. Let me just see whether did somebody put something down in chat here. No, you go away.
I put something in a long time ago, maybe
Oh,
somebody.
okay, maybe that was, yeah, and then Scott up and Rosemary apparently was on and then had to. Bill probably, and I know Bill's probably heading to the building for the Fellowship Council meeting. All righty, well, thank you for your attention. Thank you for attending. And if there's something else you want to hear about, I can either do it privately or we can do another one of these at another point in time.
That was great.
All right,
Great.
Thank you.
Thank
you're
you.
very welcome.
Thank
Great,
you.
Thank you
Laurie.
very much. Thank you.
Thank
Laura.
you.
Welcome.
Bye.